me ask Dr. Sandeep Atabar to formally invite Dr. Herman Richard Spuran, past president of SMICS and past president of ISHLT, for next presentation. Over to Dr. Sandeep Atabar, please.
It's a great honor for me personally. Dr. Herman Reichsbrunner is the teacher or colleague of my teacher, Dr. Shivadasan from Singapore. I've heard so many great things about him, and I'm so glad to be able to do this introduction today. Dr. Reichsbrunner was born in Munich, Germany on April 20th, and after graduation, after high school in Munich, he went on to the University of Munich to study medicine. He graduated in 1985, finishing his MD thesis summa cum laude, which to most of us is the highest honors in when you graduate in medicine. The same year, he started his residency in the Department of Cardiac Surgery in the University of Munich. In 1987, he went to the Department of CT Surgery at Grote Hospital and Red Cross Children's Hospital at the University of Cape Town. We all know, made famous by Christian Barnard and the first heart transplant, for a 2-year training in pediatric cardiothoracic surgery and cardiac surgery. In 1989, he went back to the University of Munich to finish his training in general surgery and later on in cardiothoracic surgery. In the year 1992, he received his doctorate in philosophy at the University of Cape Town in South Africa. He later on went on in 1994 to Stanford for a fellowship in cardiopulmonary transplantation. In addition, he has great interest and has worked in the transplant laboratories on pathomechanisms and the therapy for chronic rejection after lung transplantation. In the year 1996, he went on to the University of Dresden as a senior surgeon in the Department of Heart Surgery, where he finished his German PhD in the year 1997. Later on that year, he also went on to the University of Munich as an associate professor of cardiac surgery, focusing on minimal invasive and robotically assisted heart surgery, in addition to the field of heart and lung transplantation. In the year 2001, Professor Reichsbrunner became chairman and full professor in the Department of Cardiovascular Surgery at the University of Hamburg. And in 2005, he was appointed the medical director of the newly founded University Center at Hamburg. He served as the president of the International Society for Minimal Invasive Cardiothoracic Surgery, as well as the most illustrious International Society for Heart and Lung Transplantation. Since the year 2016, he has an affiliated professorship in adult cardiothoracic surgery at the University of San Francisco. It truly is an honor and pleasure to introduce Dr. Reichsbrunner. Over to you, sir.
Thank you very much, Sandeep, for this kind invitation. I appreciate that very much. Of course, you worked with my dear colleague, Siva in Singapore, and he, of course, very often mentioned your name. Yeah, I'm very grateful to Yugal Mishra for inviting me to this meeting. It's a great honor. I love India, and Yugal will remember that I've been there several times for different meetings. I was kindly invited. And if I may start with a funny story, that I was invited for the opening of the Escort Heart Institute, well, almost 20 years ago, I think, when that took place. And I was supposed to give a speech which I didn't know about. And it was basically sitting on the podium next to the president of India. And I only heard about this speech about 5 minutes before I had to give it. So I was pretty nervous, as you can imagine. It worked out very well. The president at that time was a very kind man. He was a physicist, if I remember correctly. And he was very interested in new technology of cardiac surgery. So that was a fun meeting. So I have a lot of friends.
Just to interrupt, he's known as missile man of the India. You see our strength in the missile. This was Dr. Abdul Kalam.
Yes.
I absolutely remember in a podium sitting next to me, and he was the one who entered into the operating room and started our robotic programs. I remember
exactly.
that. Right.
Yeah, and he sat on the robot. I do remember
right.
that.
We make him to sit while and that was a fabulous. I should say the Scots those were the days when we were really trying to bring any technology from US and Europe within a span of 3 to 4 years when they instituted in North America and Western Europe. Over to
Yeah, that was really impressive. And so I've been there several times. I love India, so it has been a great pleasure to accept this invitation. I'm very grateful to you. It's also very good to see Dr. Gokale in the audience, which I've met on several international meetings in the past. And of course, a very good friend of mine, Nicholas Dahl, is sitting on the podium. So I think I have nothing to fear about today in the question and answer phase of the talk. Yeah, so I want to start, and I was asked a similar title, and of course, Sebastian Schulte-Eitrup and myself, we spoke on the phone before because we didn't want to tell you the same thing. So we decided that he would focus more on the mechanical circulatory support side, where he's, of course, an excellent expert on this field. But I would try to focus on different aspects of heart failure surgery and covering more aspects and I will very briefly talk about mechanical circulatory support, but I will not do that too long because you've heard that. So basically, those are the three subjects I wanted to talk about. I wanted to talk about first, which I think is a very important subject, minimal invasive treatment of functional mitral regurgitation, because very often patients suffer from mitral regurgitation in combination with heart failure. Then I will talk a little bit about our techniques on minimal invasive valve implantation. I will hold that very brief. And then it will be a pleasure of mine to talk about heart transplantation, because you know that a few years back, we celebrated the 50th anniversary of the first heart transplant in Cape Town, where I had the pleasure to work as well as at Stanford. So I will show you hopefully a few entertaining pictures in case people have fallen asleep by then. Hopefully these entertaining pictures will wake everybody up again. So when I talk about surgical mitral valve repair, of course, very often we hear excellent talks about degenerative mitral valve disease, which according to a Carpentier's classification would be a type 2 failure of the mitral valve, whilst the functional mitral valve repair is either type 1, which is annular dilatation, or type 3, which is a restriction of the leaflets. Now, first, I want to briefly talk about type 1, which is mainly, there's nothing wrong with the leaflets, nothing wrong with the papillary muscles, it's just a dilatation of the mitral annulus. And therefore, Steve Bowling in the mid-90s described first the technique of doing an isolated annuloplasty for patients with functional MR. And first they used the classic Carpentier ring, but later on, special rings were developed for functional MR, like the IMR etiologic ring by Edwards. When we looked at the data, and this study is coming from Steve Bowling's group, one did see no clear effect of the annuloplasty on survival of the patients. Of course, patients were less symptomatic, they had less functional MR, but survival was not really different to patients which did not receive an annuloplasty. And here, functional MR type 3B, we of course more often see that now these days, which is a restriction primarily of the posterior leaflet due to either an infarction or a ischemia of the posterior papillary muscle. So the leaflet is basically being pulled down in addition to an annular dilatation. So very early, Bob Mitchell already published a study on ischemic MR, whether or not it makes sense to do an additional annuloplasty to a CABG procedure. Now, if you look at death and at the MACE events, unfortunately, we did again see no major difference whether we did CABG alone in these patients or CABG plus mitral valve repair. So mitral valve repair, they concluded, did provide a more durable correction of mitral regurgitation, but it did not significantly improve survival or reduce overall adverse events, and it was even associated with an early hazard of increased neurologic events in supraventricular arrhythmias. So unclear data, what should we do? Should we repair the valve? Should we not repair the valve? Another study, which was published about 5 years ago by Dan Goldstein, is well, maybe we should just replace the mitral valve to avoid recurrence of mitral valve insufficiency. And this was a study which was done comparing mitral valve repair and mitral valve replacement for patients with functional MR. However, one must consider that in this particular study, first, it was a highly selective study. Second, the whole subvalvular apparatus of the mitral valve was kept intact. So, which is difficult, which is not easy to do, as all of you know. So, therefore, it's a very special study, but there was no difference in mortality in the two groups, but a higher recurrence of mitral valve regurgitation, as you can see here in the mitral valve repair group, as to be expected. However, if we look at review studies, at meta-analysis, and compare mitral valve replacement or mitral valve repair, basically more on a daily basis, not so much on a highly selective study, we do see a difference, as all of you know, that mortality is higher in the mitral valve replacement group, and the risk of death is higher. Therefore, I would be careful to, because of one paper now, to change the guidelines and switch over to just do mitral valve replacement. However, I think it's important to mention that maybe annuloplasty is not enough for doing mitral valve repair in patients with functional MR. And you have, in my opinion, you have to combine mitral valve repair, annuloplasty with subannular repair techniques in order to achieve a more long-lasting result. Several authors have done that. And this is the ring and string technique, which was published by Jochen Schäfers from Homburg in southern Germany, where there's also an approximation of the papillary muscle through the mitral annula, and it's actually externalized, as you can see here. And during reperfusion, this is tied, and to achieve an approximation of the papillary muscle. Another interesting study is papillary muscle approximation. So you basically put a ring around the papillary muscle and pull them together in order to avoid a restriction of the posterior leaflet. Another study, which was published by Michael Burger, now in Leipzig, was cutting of the secondary codi to avoid a restriction. It's also a technique which can be used. Another technique is called posterior leaflet extension, where you insert a pericardial patch into the posterior leaflet in order to widen the leaflet and again to reduce the restriction of the leaflet. Now, in my department, we've published in Innovations a few years ago, together with Evaldas Gadauskas, who was the first author on this study, a new technique of papillary muscle approximation, which is in my eyes a pretty simple technique. And therefore, I wanted to show you that a little bit more in detail. Evaldas also published a multi-center analysis on different approaches for subannular repair for functional MR. And in this meta-analysis, it was shown that there's a clear advantage, both with regard to recurrence of MR, as well as with regard to survival, in favor of subannular repair. So maybe we have just to do a better job in doing mitral valve repair. So this is the original paper, which was published in Innovations on papillary muscle reapproximation in combination with a restrictive annuloplasty, for example, with an IMR ring. And that's what's done. And I will show you a short video also in a minute. But here you see that 2O Gore-Tex sutures are placed with pledgets are placed around the anterior and the posterior papillary muscle. After you've done that, you pull the stitches, the 2O stitches, through the mitral valve leaflets at the level of the annular plane. And later on, when you fix the valve, when you fix the annuloplasty ring, you then stitch these sutures, and you do that between A2 and P2, and between P1 and P2, and then between P2 and P3, you stitch it through the annuloplasty ring. Now, of course, when I talk about minimal invasive, and that's of course one of the titles of these presentations, I mean truly minimal invasive. And it's a technique which was originally developed at Stanford when I was there as a fellow in '95. But of course, at that time, we used a right anterolateral thoracotomy. We used a spreader. and we used the endo-aortic balloon catheter. It was all pretty difficult and cumbersome procedure. And we have really simplified that in many centers in Germany. Niklas Doll is an expert on this field as well, where we really make just a 3 to 4 centimeter incision, as you can see here, just like a port. We do not use a thoracotomy spreader because we think it causes a lot of pain after surgery if you use a thoracotomy spreader. But we use, what's very important in my eyes, is we use a 3-dimensional endoscope and an HD presentation of the TV. And you see here, it's really amazing, like you watch Avatar, it's really amazing how the structure gets out. You almost have the impression that it gets out of the monitor towards your eye. And it's very good to have a better depth perception, which is very important in mitral valve repair. And I show you a brief video of the setup of our technique. In male, we use a subauricular incision. As you can see here, it's not larger than about a 2.5 centimeter. Then we use a soft tissue retractor. And then you see the lung. And then we insert the heart-lung machine. We also do that, like we do for TAVI procedures, not a cut down, but we do it through a puncture Seldinger technique. And you can see here the vein and the artery is nicely. And then we have this picture at the end where you have the 3D endoscope. Then you fibrillate the heart. You use a transthoracic clamp to clamp the aorta. And then you test the valve. In this case, it's a degenerative mitral. I will show you in a minute a functional video. Nice exposure of the valve, 3-dimensional picture. It's a real beautiful exposure. And since we do that, and I must tell you that in Germany, meanwhile, 55% of all mitral valves are done in this fashion. So it's really a perfect technique. And if you have done that and have a little experience on that, you do not want to return to a sternotomy because the view is much better using this approach. Now, this is now functional MR. Now, here you see how the stitches are pushed actually through the annuloplasty ring. They are, of course, already, as I told you, put around the papillary muscles below the valve. Then we do a water test. You see the restriction of particularly the posterior leaflet. You see how it really, the tenting of the posterior leaflet. And now you see when we tie those sutures, you will see how nicely the posterior leaflet comes up. You see how it comes up? Yeah, and you have a nice coaptation of the mitral valve on the level of the mitral annulus. And this is very delicate, and you have to use this knot pusher very carefully. We also fix the valve with a little clip now in order not to lose the tension, which we have established. And as I told you, you do that between P2 and P3, but you also do that between P1 and P2, and you see how also nicely this part of the leaflet comes up. And then the coaptation really is on the level of the annular plane, and you have much less tenting than before. We've published our data in the European journal recently, looking at 2 groups, subannular repair versus annuloplasty alone. Primary endpoint was reoccurrence of MR greater than 1, and then later on 2 years after surgery, secondary endpoint survival, and so forth. You see that the baseline characteristics were not really different in the 2 groups. And also cardiopulmonary bypass time and cross-clamp time was not really significantly different because it doesn't cost much time to put these 2 sutures through the papillary muscle and the annuloplasty ring. But we see that if you look at the tenting height and the tenting area, which is a marker for restriction, you see a significant improvement if you do annuloplasty plus subannular repair. And also the valve angles, which is also a predictor for valve tenting, is significantly better if you do a subannular repair. Now, if you look at the data 2 years after surgery, we see that both freedom from MR greater than 2 or survival were significantly better in the subannular repair group. We are now running a German prospective multicenter a study with several experienced centers in Germany with a sample size of about 300 patients. The study is still running. Of course, as we all know, cardiologists are also in this field closer than they appear. But on the other hand, we need honestly say that there are a lot of patients which we do not want to operate on because they have either reduced LV function, they have a porcelain aorta, they suffer from significant comorbidities, and so forth. So we've been the first center in Europe using the mitral clip in Hamburg. It was late 2007. And at present, we do about a total of around plus minus 100 mitral clip procedures per year. So we're very open to this new technique. It's a common, but all patients are verified by the structural heart team. And there's always a surgeon involved in the procedure also. And it's a very close collaboration with our cardiologists. And we know the data. I won't go into detail from the MITRA-FR study, but particularly from the COAPT study, that at least there's a hint, I would say, that, that repairing the mitral valve for functional MR improves survival. By the way, that is the first study, the COAPT study, who ever showed that. No surgical study has ever shown a survival benefit. So that's why I truly think it's important. Those are important studies. But as I told you, we discuss all patients with functional MR in the heart, all of them. And if we think that a patient is clearly operable, we would go for a minimal invasive repair, as I've showed you in the video. If we see contraindications, of course, if he has concomitant surgery, which often is the case, then we do a conventional procedure. But as I told you, we have about 60, 80 patients per year where we think they have high risk or contraindications to surgery. In those patients, we use the mitral clip procedure. Now, in the next part of my talk, which will be a short part because that has beautifully been explained already by Dr. Schulte-Eistrup, I will just mention a few details. And you see that the numbers of heart transplantations are about a third of the numbers of LVAD implantations. And we have a severe donor shortage in Germany. Therefore, heart transplantation, unfortunately, are not done as often as we wanted it to do. But LVAD implantations, we do around 900 a year. Last year was a little less, which was probably due to the pandemic. Now, when we talk about left ventricular assist devices, of course, it all started, as you will know, in Salt Lake City in 1984 with the total artificial heart. It did, of course, start earlier at the Texas Heart Institute, but the first successful implant was done in Salt Lake City. And then two systems started. The Thoratec system was used as a BiVAD or as an LVAD procedure, was started same time as the NovaCore implantation around in the early 90s. And later on, of course, we went away from this large ventricular assist devices to smaller ones. This is the axial flow pump, the Micromet DeBakey pump, or the HeartMate 2, which was used mainly in the 90s and in the early 2000s. But now we almost, as Sebastian showed you, we almost exclusively use, of course, centrifugal pump today for LVAD implantation. And as you've also seen, the survival rates, the early survival rates have always improved, and third generation devices now have a 2-year survival rate of far over 80%, which corresponds to the ISHLT data of heart transplantation. But one has to keep in mind that later on, those curves diverge. And of course, heart transplantation has a much longer longevity for the patients. It's also in the current guidelines when a patient is eligible for a LVAD, it's used as either destination therapy for patients which do not come into consideration for transplantation, or it's used as a bridge to transplant for patients which need a bridge on their way to transplantation. We have an American annual report, which is called the INTERMAC study. And this is published regularly, usually in the Journal of Heart and Lung Transplantation. And you see here that there's a rapid rise of continuous flow devices over the last years, and also a significant improvement of survival as well. And we also do see a significant advantage of centrifugal pumps versus LVAD axial pumps, which is mainly the HeartMate 2 pump. But we do still have our Achilles heels in mechanical circulatory support, which are neurological complications and infections and bleeding. These are still the major events, which is also shown in this multi-center study, that we have a decrease in these complications, but it's still definitely present, and particularly driveline infections are still a major Achilles heel. Now, the latest big multi-center study is the Momentum 3 trial, which uses the HeartMate 3 device, and I'm sure a lot of you have read that article in New England Journal of Medicine comparing HeartMate 2 versus HeartMate 3, and we do see a significantly improved event-free survival comparing HeartMate 2 to HeartMate 3, with also a significant decrease in stroke and pump thrombosis, which is that was also a bit of the problem of the axial flow pump. So definitely improved data. Minimal invasive LVAD implantation is done in different ways. You can either do 2 thoracotomies, or you can do a partial upper sternotomy and a thoracotomy. Sebastian has shown that to you. So this is a left mini thoracotomy, the sewing ring implantation, and then of course you have to tunnel the outflow graft, and then you can do the proximal aortic anastomosis either through a right anterior thoracotomy or to a partial upper sternotomy up to the center view. In most of our patients, and we published that in ASIO in 2014, in most of our patients we use the right anterior thoracotomy, because particularly for bridge to transplant patients who undergo a subsequent transplantation, it is much easier, the transplant procedure itself, if it's a minimal invasive approach. And in our data, we do not see a significant difference in survival, but at least minimal invasive is not worse than a sternotomy approach. There was also the HVAD trial, which was published at that time by Hardware, which was later on bought by Medtronic. And the HVAD trial was basically a single-arm study, 144 patients enrolled. And those are the survival, event-free survival and survival curves, so excellent results basically. But as Sebastian mentioned, there's no real prospective multi-center trial comparing the MIG approach versus the sternotomy approach, which is still outstanding. So what I wanted to mention, what was important to me is the current treatment strategy is basically, we see patient with heart failure, we see does he have a contraindication to transplantation. If no, if he does not have a contraindication, we wait and see. But then if there's an acute decompensation of the patient, we basically, if we see that, we put a ventricular assist device in, and then later on maybe do a heart transplantation. But the potential future treatment strategy, particularly in countries which is a shortage of organ donors, may be a different one. Patient with end-stage heart failure, look, does he have contraindications? If he has no contraindications, we look carefully at the patient. Does he have advanced age, and does he have significant comorbidities? If it's a young patient with no significant comorbidities, this patient should still go for heart transplantation. But if there are significant comorbidities and one doesn't know, maybe a high-risk patient for transplantation, whatever, maybe the patient should first receive a ventricular assist device. And if he stabilizes on the device, he could then later on go for heart transplantation. That brings me to my last section of heart transplantation. And this is a little history. People who know me well know that I really love the history of heart transplantation. And first, it was published in the early 1900s by Drs. Carrel and Guthrie. And Dr. Carrel did receive the Nobel Prize for his work on vascular anastomosis and transplantation in 1912. Then it all started in the 1950s with experimental orthotopic transplant by Webb and Goldberg. And then later, the colleagues Laura and Shumway, first in Minnesota and later on at their final location at Stanford University, they started with orthotopic heart transplantation. There is the landmark paper was published by Laura and Shumway in 1960. And I had the pleasure when I was in Cape Town to work with Chris Barnard, a very peculiar personality, but impressive. And I must say he had the guts to go to America, to see the technique, to learn everything from the American surgeons, and then did the first heart transplantation, as we all know, in December 1967. And that paved the way for and that's what also Dr. Shumway always said, it paved the way for the first successful orthotopic heart transplantation in January 1968, done by Norman Shumway. And so basically, I'm sure many of you have been to Cape Town. Actually, Cape Town from you guys is not that far away, is it, from us, pretty much, but it is a beautiful city. So not only does it have a beautiful transplant museum, where you can watch the history of transplantation, but it's also a great location to spend a holiday. And this was this was actually done during my PhD graduation in 1992. And next to my dad is Chris Barnard, and he's a very funny man. I had a good time when I worked with him down there. But I go a few years back, which might be interesting to you. In the 1967, 1968, Louis Washkansky died 3 weeks after transplantation from severe pneumonia, and he didn't really know, what was the cause for that. And he invited specialists, interesting enough, from Germany. And you see on this picture, you see Hans-Georg Borst, you see Roland Hetzer, and you see Walter Brendel. And the reason why he invited the supervisor of my MD thesis, Walter Brendel from Munich, because he was one of the first medical doctors in inventing anti-lymphocyte globulin. So the second patient, Philipp Bleiberg, some of you might remember, of course, very few ones probably. He lived for 18 months, which was a sensation at that time. And this was due to receiving anti-lymphocyte globulin. But then, of course, the horse went through a little bit with Chris, and he was, of course, on all the newspapers, and he was invited by the Pope, by the American president, and was in love with Gina Lollobrigida and so forth. So he had a very colorful life after the first transplantation. There's a very interesting book, which I recommend you to read, which is called Second Life by Chris Barnard. It's a very interesting book. And there was always the discussion of a severe sort of hate between Shumway and Chris Barnard. And actually, this was not the case. Shumway was very happy that he was not in the limelight for the first heart transplantation. He actually complimented Chris on the first heart transplantation. This is the picture from the Transplant Museum in Cape Town, which, if you go there, I strongly remember. And this is the first, when you enter the Transplant Museum, this is the first picture you see, basically congratulating Laura and Shumway for their pioneering experimental work on heart transplantation. This is also interesting because it was the first international congress on heart transplantation. So if you want to say the first IHLT meeting in 1967, and again here, Stanford was there. This is Ed Stinson, who was for many, many years, also still during my time, he was the director of the heart transplantation program. And this, of course, is Denton Cooley and a lot of other important surgeons visiting. Now, when we prepared the first heart transplantation in Germany, I had the pleasure to work there as a student. This is Bruno Reichert, who later on did the first successful series of heart transplantation in Germany. I, of course, was a student. I didn't participate in the operation. I was a scrub nurse in this case. And then we helped, as students, we helped Bruno to establish, this was the first long-distance donor run we did when we harvested a heart in Hanover in 1981. Then, as Yugal mentioned, we all went to Cape Town in 1984. Bruno became the successor of Chris Barnard. I joined him in 1987 for 2 years, and we did a lot of research and clinical work on heart transplantation. Also, we did a lot of work on allotransplantation and xenotransplantation in the laboratory. And I got 1992, I received the PhD graduation. In 94, I had the distinct pleasure of going to Stanford University for a cardiopulmonary transplant fellowship, which was probably one of the most exciting times of my life, working with these two gentlemen. Noam Chambray was still there. He was not the chief anymore, but he was still there. And I worked a lot with him and had a lot of fun with him. The chief at that time was Bruce Wright, who did the first combined heart-lung transplantation in 1981. Very sincere gentleman, and it was a great pleasure to work with these guys. Many years later, we all went back in 2017 for the 50th anniversary of heart transplantation, which was a very moving event, because you must imagine, probably maybe similar as in India, you know, South Africa doesn't have a lot of money for fundraising for congresses. So this meeting was done without any industry support. Everybody, also the invited speakers, paid their own way to go to the meeting. And it was a very moving event. And this is very interesting because this is the son of Chris Barnard, who gave the opening speech. Very moving because he looks exactly like his dad. And he did a very moving opening of this anniversary. And it was a beautiful, you see a lot of, this is Peter Ziller, who just retired from chairmanship of cardiothoracic surgery at the University of Cape Town. Here, of course, with Alain Carpentier, and here a lot of renowned surgeons here at the celebration. In January 2018, I went to Stanford when they did their 50th anniversary. Again, a very moving event. Of course, unfortunately, Norman Chambray had passed away. But this is, as I showed you on the other picture, Ed Stinson, who directed the heart transplant program for many years, and Bruce Wright. Now, a few data on transplantations. So altogether internationally, we have still stable numbers, if not a bit increasing. So it's not like in some countries where there's a decrease in transplantation. Internationally, fortunately, it's not the case. We all know the indications being either dilative cardiomyopathy or ischemic cardiomyopathy. Of course, in pediatrics, it's also a congenital heart disease. And this shows you how nicely the results improved over time. We have 1 year survival rates of close to 90% now. We have 5 year survival rates of close to 80%, and 10 year survival rates of close to 65, 70% now after transplantation. The functional status of the patient is excellent. So about 80% have no major limitation when they live their life. Maintenance immunosuppression has changed over time. Tacrolimus plays a big role these days, has sort of a little bit been exchanged with cyclosporin, and it's in combination usually with mycophenolic acid. And of course, sirolimus, everolimus, the M2 inhibitors are on their way, replacing MMF in certain patients, and prednisone, it can usually be discontinued after some years. Major causes of death in the early phase, it's still primary organ failure. We still see primary organ failure here as the main cause of death in the early phase. Later on, infection, and then chronically either malignancy you see or graft vasculopathy, which are the main causes of death on the long run. Of course, in Eurotransplant region, we have the problem that the wait list is much larger than the number of transplantations we perform. Therefore, we need new concepts. That leads to the fact that we have very different organ donation rates in Europe. We have excellent countries such as Spain, which has excellent numbers. We have Austria, which is next to Germany, has also very good organ donation rates. Germany has very bad organ donation rates because we have the law of consent, while Austria has automatic consent. So if you don't refuse, you're automatically an organ donor. So you can see, which is maybe interesting compared to your numbers also in India, that there's a big difference in between the European countries also with regard to organ donation. That leads to the fact that in Germany, the number of transplantations went down over the last years. We've done over 500 in the mid-90s and now they're up to about 340 these days. Waiting times in Europe are much longer than they are, for example, in the US. And what's also interesting, the donor age is much higher in the last years, as it is, for example, in the US, because in the US, we have a lot of donors which have brain death as a consequence of drug abuse, and also gunshots are an important source of organ donation in the US. Therefore, the donors are much younger in the US than they are in Europe. The average waiting time, like this gentleman, is about a year now for transplantation. Also, if the patient is listed on high urgent. So we definitely, like we've done successfully in lung transplantation with the lung allocation score, we need a new distribution system also for heart transplantation, basically covering urgency as well as probability of success. It doesn't make sense to transplant a 68-year-old guy on ECMO who has a probability of survival on 40%, while a 20-year-old guy never reaches transplantation. So we have to carefully select those patients. Therefore, we work on a cardiac allocation score at the moment in Europe, which is a combination of death on the waiting list compared to post-transplant survival and risk factors for post-transplant survival. So that's a task which we are working on at the moment. Of course, we have to consider elderly patients as a separate group. Netherlands has changed the law. They have basically a new law which is basically allows explantation of the organs unless the relatives definitely say no. What's important, and I want to mention at the end of my talk, is that treating patients with heart failure is a multidisciplinary treatment. It's not anymore a surgical task alone, which it probably has been in the 80s and 90s. Very important in my eyes are heart failure cardiologists, which we work very closely. Very important psychologists, both for VAD implantations as well as for transplantations. Very important also close collaboration with the general practitioners, nursing staff, and then the key are transplant and VAD coordinators. They are the soul usually of the program, and it's very important. And what we do is we meet on a weekly basis in Hamburg, where we discuss every patient with heart failure. So here we sit all together. This is the surgical director, Alex Bernhardt, who runs the surgical program at the moment. This is Markus Barton, who runs is a transplant physician. Michael Ruczynski is the cardiology director of the program. So basically, this is a whole team of nurses and doctors discussing patients with heart failure. We do that every week on a weekly basis, basically. Well, with this, I want to finish my talk. I want to thank you very much for your attention. I want to thank my very dear Indian colleagues for inviting me to your conference, and I'm very happy to answer any questions.
Thank you so much, Dr. Experimenter. Yugal, please, all yours. The stage is yours.
So, Sandeep, why can't you start with, make a comment? You are one of the most experienced transplant and VAD surgeon in the country, then followed by you, Dr. Gokhale. So why can't you start with an overview where we are heading for in India? So Herman has stated the the status in Europe and Germany. What is our status now, and how the COVID has impacted the transplant donation and, of course, enrollment of the patients?
It's a very
you
interesting.
And Dr. Gokhale can come on.
Yeah, it's a very interesting question, Yugal. Actually, it's interesting that last year where we had the pandemic in Germany for 9 months, did not impact our transplant numbers. Actually, we've even done more transplants than we've done in the year before. We've done 340 last year. So it has not impacted neither the numbers of heart nor the numbers of lung transplantation. But of course, one needs to be very careful with patients on the waiting list. So definitely they have a prioritization for immunization, the patients who are on the waiting list. And ideally, one should not transplant them within a window of about 3 weeks after immunization. But if there is a donor organ, we would also not decline it. So we would take the risk, but optimally one should wait 3 weeks. Now, what's also interesting, there is a very interesting series was published just a few weeks ago on lung transplantation in COVID patients who do not recover the lung function. We did not dare to do that now, and I'm not aware of any of these activities in Germany, but this has been done, and the results were actually pretty positive. So one has to see how that impacts the lung transplant area.
So Sandeep can talk about the lung transplant in COVID in Indian experience. They started and they have done pretty well, and that Dr. Bala and then followed by Dr. Gokhale. So, I very interesting. The Dr. Gokhale could carry the heart in a metro, in a metro. That's something, And anyway, Dr. Gokhale is going to talk about his experience. But let's start with the Dr. Sandeep, his experience of lung transplant in a COVID period and post-COVID destroyed lungs, how he coped up there.
Yeah, thank you, Herman. Thank you, Dr. Yugal. I relocated in August last year. I lived in Chennai. I practiced there, and unfortunately, with the COVID hitting very hard and the lockdowns being imposed, we had a lot of patients on our wait list who unfortunately passed away while awaiting donor lungs and hearts. And there were some draconian rules. And in India, state is a health subject. I'm sorry to take you a little back, but I think it's always interesting to understand how the healthcare system works in the country. And if for Indian states, and there are more than 25 of them now, state is a health matter. I mean, health is a state matter. So they are allowed to make those independent decisions. Some states that used to be very forward-looking and forward-thinking with organ donation, and thereby automatically with organ transplantation, whether it be livers, hearts, and lungs, decided to take a back step and be more protectionist during the COVID era. States like Karnataka and Tamil Nadu, which is largely Chennai, closed down to a large degree. They clamped down on the number of donations. They even asked many of their donor coordinators to probably not go through the hard yards of mobilizing or motivating relatives for organ donation. And that actually impacted heart and lung transplantation immensely during these times. Liver transplantation continued, likewise kidneys, because 80% of liver and kidney transplantation in this country continue to be a living donor, which is a strange paradox, which is probably diametrically opposite to what happens in. I hope you can hear me.
Yeah, very clear.
Yeah. So with and that's just talking about why I moved. I realized that the current state that I live in, and I'm a cohabitant of Hyderabad now. Dr. Gokhale hails from Hyderabad. He can probably tell us more about Telangana and Hyderabad. It's a state that was formed a couple of years ago when it divided from the greater Andhra Pradesh area, and it continues to be probably leading in its not just its growth pattern, but also the forward-looking thoughts of the current chief minister. It's probably the tech capital of the country right now. It's also probably moving on to be a transportation hub in a major way for the country. So they were always very positive about continuing organ donation, and that's one of the reasons why I moved here. I haven't regretted it one bit for the last 8 months. And coming on to what has happened hence is a lot of patients from all over the country have now been on various forms of not just mechanical ventilation, but also extracorporeal circulation for between a week to 3 weeks after they've turned COVID negative. And with no respite, most of them have moved down to transplant centers in Hyderabad and Chennai, where they were awaiting a donor organ. So with lockdowns in most parts of the country, all that we could look forward to was local donor organs being available. One of the peculiar challenges in India is there is almost a term that we could call antibiotic abuse. There is absolutely no standard modality for ascribing or prescribing antibiotics for patients who are admitted in intensive care units. As you know, India is probably one of the biggest manufacturers of pharmaceuticals in the country. They've also taken care of pricing in a way that it is affordable for most of the population. And unfortunately, that leads to many manufacturers of a single molecule, leading to easy availability and even easier modes of prescription, which leads to widespread antibiotic abuse, if that's the term that I might use in. And we are faced with a slew of multi-drug resistant organisms, which are probably resistant to almost every single drug that's available in the market. And that probably is our biggest challenge as transplant physicians. So we would end up having patients who had multiple rounds of steroids, remdesivir, tocilizumab, every single experimental therapy on the planet for COVID. Most of them would be septuagenarians, sextuagenarians, people in their late 50s with various comorbidities. And unfortunately, once in a while, a spattering of young individuals for no obvious reason would be on ECMO. And I did have a word with a lot of my colleagues in the West, especially in the US, because I have a couple of very close friends in the lung transplant circuit out of UT Southwestern and also in parts of New York. And they told me that, unless you wait for 6 to 8 weeks, doesn't make sense for you to transplant. This is very early on. And sadly, none of our patients would even survive beyond 3 weeks on an ECMO. We began to realize that probably we could use that very, what would I say, convenient definition of non-resolving pneumonia, and probably consider some of these patients for a lung transplant as early as 4 weeks on ECMO. And that's what we've actually now very aggressively pursued. And to cut my long story short, because I thought I would give you a snapshot of what is happening back in India, we've now done, at my center, we've now done 10 COVID double lung transplants. The median ECMO time has been 34 days. The longest ECMO run has been 56 days before we got a donor lung. We have 80% survival at 1 month and 3 months now. 2 patients continue to be, 2 patients did not survive. One of them had probably anoxic brain damage post-transplant. It was probably a continuation of what had happened before he was put on ECMO. Though he was responsive, unfortunately, his brain injury was compounded after a double lung transplant. Though when we took him up for surgery, he was responsive and neurologically intact. So the other patient had a reactivation of CMV infection and succumbed to renal failure, which was intractable simply because we gave him multiple rounds of IV ganciclovir, and he never recovered from that. So these were our 2 mortalities. We've been reasonably happy with what we've done right now. I know it's probably not something that would match what the West can do, but sadly our resources are so limited, and our opportunity to help so many patients who turn up at our doorstep force us to make some of these very difficult choices. Thank you for your time, Herman, Dr. Dole, and Dr. Schulte.
Thank you, Sandeep. I think it's really very interesting and excellent, and I really hope that you submit your work to the Journal of Heart and Lung Transplantation. I'm sure that Dan Goldstein would be very happy to receive your work, because it's a very up-to-date subject, and there are not that many centers who have done lung transplants in COVID patients. So it's a pioneering work for sure. And I just read an article the other day that in Kyoto they did a living-related lung transplant in a COVID patient, which is, in my eyes, that's a very gutsy thing to do. But as Dr. Shambwe said, it's an operation with a potential 300% mortality. So even more gutsy to do it in COVID patients. But congratulations to your experience and to your program. I have a high respect. I know, of course, the infection numbers in India, and I know that this is a huge burden for all of you to treat these patients. Also, younger patients, unfortunately, very often, of course, with significant comorbidities.
Over to Dr. Gokhale. Can you give your experience, your recent one, carrying the organ in the metro system, which is something you have to listen there. You are unmute, please. You are on. Yeah.
Professor Herman, that is a very nice presentation. Thank you for taking us through the story of heart transplantation from the beginning, how things have evolved, because it's always interesting to look at the history in situations like this. Many of us do not know the total thing, like all those letters to from United States to South Africa, congratulating people, how they have done, how people have survived. It's a very interesting story. Here in this country, still we struggle, as Sandeep has said, we all have some success, but many situations, difficulties we face, we try to evolve in our own way. What exactly is available in Germany or in America doesn't always apply to us. For example, one of the things for transporting organs is a green channel, which happens in this country, wherein the traffic police stop all the traffic on the road so that we can get the organ, especially the heart, in time for surgery. And very interesting to know that in our country, the number of transplants have actually become more in COVID season. For us, it is a big problem. Our donor rate has come down. One of the reasons may be with our population, we did not have enough beds to manage patients with COVID. So probably everyone is tired, overworking, to declare brain death, work on organ transplantation, and extra work for many people. For surgeons and physicians who are involved with the transplant is a primary work. For most of the others, like intensivists and nurses, they're all so busy with the other patients. Our organ transplantation rates have come down dramatically in the last 3 months. As Sandeep said, again, it has picked up. But now with what is happening in this country, we have our COVID rates are going up. Actually, All India Institute of Medical Sciences at Delhi has announced that from Monday, they are closing all the elective operating rooms. So only emergency surgeries will be done. So we are going to have another big lacuna, I'm sure, in the next few months. And we have to innovate and work on our own ways. See, there are many problems we face. Of course, I wouldn't say problems. There are many challenges we face in this country. One of the things is, of course, patients have to pay from their pocket. The health insurance is non-existing for transplants, especially. So it being a very costly procedure. Like, for example, a COVID patient, an elective heart transplant may not cost a lot of money. It's much cheaper. But someone who is COVID, admitted in the hospital in intensive care with ECMO for a few weeks, by the time their finances are exhausted for most people, and then do a transplant, and we are not sure how things will turn out. So not many people could afford in this country. And one such thing is, of course, Yugal was mentioning was about recently we had to transport a heart in a metro, in a dedicated metro from one end of the city to the other end of the city. See what happens, cities like Bombay, Delhi, Hyderabad, Bangalore, they're all ever growing. And to transport an organ from one end to the other on the road itself may take about 1.5 to 2 hours, even though there is a police stopping, because there are always people who are trying to chase in front of these ambulances in our country. So in one such situation, we made use of a metro. It is a very interesting experience that we could transport in a dedicated metro, because there are no stops, no traffic as such. You stop all the vehicles in that lane, the metro in that lane, and we could get it in about less than half the time, and especially useful in sick patients when we are transporting heart. And that patient was fortunately doing well. This is another thing which we are trying to invent in our own country, our own methods. And I want to know, actually, for heart transplant, still we are doing through sternotomy. Is there any minimal invasive procedure through which you can do sternotomy, like a thoracotomy? Are you aware of anyone having done a transplant through minimal invasive non-sternotomy approach?
Well, not in the recent years, I must say, but the early work was done through a thoracotomy. I mean, that was the primary cardiac access, of course, in the 60s. And so there's very early work, but not that I really am aware of. I mean, what we sometimes do in women, that we do what we call a limited incision, that we try really to spare on the upper end and the lower end, and then dig out the sternum, but do a complete sternotomy. I think there's no way you could do a transplant through a partial upper sternotomy. I mean, Nico Doll is one of the most experienced minimal invasive surgeons I know. So Nico, you want to comment? Could you imagine to do a transplant through a partial upper sternotomy?
Thoracotomy?
That won't be my approach. I think a full sternotomy is fine for this. It is too difficult, I think.
Yeah, me too. Even a thoracotomy. I mean, you can do, but from my experience, and I would also value Nico's opinion on that. On the early experience on minimal invasive mitral valve repair, where we did basically a small right anterior thoracotomy and used the rib spreader and so forth. Actually, the pain and discomfort of the patient for the first few days was more than patients undergoing a sternotomy. That has only improved now because we get rid of a rib spreader, and really when the drains are out, the patients are feeling very well. I don't know, Nico, is that about your experience also?
Yeah, I fully agree. That's completely correct. So I prefer the same. If you can avoid the rib spreader, then it's much more better for the patients. And in former times when we used the spreader, we put a pain catheter inside, and we stopped this. And now there's no pain, and they feel okay. Next day they walk around without any pain.
What about robotics? How advanced is it robotics in mitral valve repairs, etc. in Germany?
Yeah, that's a good question, and it's interesting because I yesterday went because they are building up a robotic chair at one of the German universities, and I'm on the subcommittee searching for a chairman for this newly created department for robotic surgery. And I must say, I watched general surgeons and urologists doing beautiful work. I mean, esophagectomy, all done by endoscopically with a robot. Prostatectomy, done fully endoscopic. Nerve preserving prostatectomy, done fully endoscopic. I'm very impressed by that, and I think that for this, definitely for the field of general surgery, urology, and gynecology, I see a bright future for robotic surgery. In cardiac surgery, which is funny because it all started with cardiac surgery, of course, in the mid-90s. And we worked on a system which was called Zeus from Computer Motion, and the Leipzig group, where Nico was also participating, they started with the Da Vinci system. And yeah, you can do it, and a lot of centers use it for mitral valve repair. My personal, but that's a very subjective opinion, is that I can do an equally well job using three-dimensional endoscopy and do a thoracoscopic procedure. I'm fully convinced of that. And I do not see a significant benefit. You must not forget that surgery, particularly in the United States, is extremely competitive. And of course, to market your department with a robotic system helps to get patients, because patients say, oh, great, a robot, I was operated by a robot, and da. So I think it's a big thing. In Germany, which is really the original country for minimal invasive mitral valve surgery, and as I told you, 55% are done that way now. Robotic does not play a role, but I'm sure Nico also has a comment on that as well.
Yeah, so we all started, I think 20 years ago, and it was very successful, but success means that the marketing effect was huge. And all the patients, they phoned us and they said, I need to have this operation. And only in rare cases we did mitral or EMA harvesting for mid-cap. And after 5 years, I think we all stopped. Dresden was one of the centers, Munich and Leipzig. And now 20 years later, one German guy started again, and he has the same effect. It's the same marketing effect. Everyone wants to go to Stuttgart now because there is a new Da Vinci system. If you put all these incisions together from these many ports, then you have at least 8 centimeters. And you have seen Hermann's incision, it's 2.5 centimeter nipple cut, and that looks very nice at the end. And we should keep it simple and safe. And now we are on a level, we have, I think this year we will go up to 350 mini mitrals per year. And this huge, easy reproducible program. And I was able to train young surgeons who are now able to do minimal invasive surgery. And robotic is nothing for everybody. So Herman, I enjoyed your talk very much, and this was very excellent and colorful and entertaining for me. And I liked it very much that you focused in your beginning on the surgical heart failure program. So how you focused the mitral valve, and this is very important. Due to the Aker and later Goldberg paper, we lost so many mitral patients to cardiologists because they said that our procedure is not has no sustainability, and they put mitral clips in these patients. And with your new technique to pull up the papillary muscle and to bring it on the level of the annulus, that can induce again sustainability. And this should be a procedure for these patients with heart failure. And I switched exactly to this, and I can really fully agree what you said. And we have to focus on surgical treatments of heart failure beside LVAD and transplant surgery.
Thank you. So let me make my comment on robotics. So when we were about to buy the robot in 2000, 2001 and 2, so I myself had extensive tour of some of the countries, and Germany was the one. I went to Leipzig, and remember, Nicholas, in 10th floor, you had a robot, the 2 console for trainee, and now there they have put in a hybrid lab. So there is no more robot in Leipzig. Then we went to Dresden, and of course, Herman had a Jews, so we were about to decide which one to get, the Jews and or Da Vinci. There was a competition. Then we went to get a training in America, and the Sudhir Srivastava and Randy Wolf, they were the 2 ones. So we try to, so my point is that was the time when the Germany was really doing a lot in the robotic cardiac. Eventually, the Leipzig gave away, and I think Jews system also did not work, but bought by the Da Vinci, and things went back. And now there's a resurgence of robotics in cardiac in USA, and with the newer devices like the Medtronic is doing, J&J is doing, Dr. Sudhir Srivastava's system is doing. Hopefully, we are going to have a cheaper robot. And the Nicholas told that some of the surgeons, they moved. I also moved from Scott because did not have a robot to Manipal Hospital, which I got a new brand. So yes, to afford a robot, a country like India is a difficult. Those were the time when we had a robot across the Asia. That was the first robot in a Scott Artistwood. And Harmony remember that, and that was really pretty expensive one. But now I think there is a hope with these new systems, which are modules, 2, 3, 4 modules, which may be cheaper. Thanks.
Yeah. Also, Medtronic is working on a system which you guys should also explore about, which I think is very interesting because they have a different philosophy on instruments. They use actually regular endoscopic instruments, much easier and much less expensive to follow up on. They want to come, I think, September, October. They have a system which they come on the market.
Sebastian can make a comment on that.
Yeah, we do not have experience. Stuttgart is another colleague in the Robert Bosch Hospital, and he started again with the Da Vinci system, with the most recent generation. And he is doing mitrals, and he published now his first 150 patients with very good results. But it's a one-man show, and I think it's not reproducible for young surgeons.
Thank you, friends. I think time is up. We got okay. Sandeep, yes, please. Your comment.
I have one question. It's a question for both the speakers and Dr. Nicholas, who's an esteemed panelist. The last report on the HeartMate 3 said that 2 years it almost equaled the outcomes or the results of a heart transplantation. What, in your view, one after another, what in your view is the future of the MCS with the heart transplant?
Well, it's a very good question, and I get asked that very often. But I think there's one thing which I want to emphasize. We certainly should not make the same mistake as cardiologists, that we look only at short-term data. Cardiologists love 6-month results, as we all know. We love 20-year results. And I can tell you that, that the first patient we did in 1981, I was a student and I showed you pictures when we harvested the heart. The first patient ever receiving a heart in Germany successfully lived for 32 years with his heart. Wow. This is unheard of course, with any mechanical circulatory support. So I do agree that within the first 2 years, now with the current results, and Jan Schmitto has just published, as usual, the Hanover Super Series of, I think, 90+% survival in the first 2 years, which is equal to heart transplantation in experienced centers. So short-term results are equal, but long-term results are definitely, and quality of life. Don't forget, we still have a drive line. Quality of life is, swimming and whatever. I mean, the quality of life is so much better in transplantation. But if you get rid of the drive line, it might change the scenario, and if you have better pumps and so forth. So I would say for the next 5 years, a good transplant candidate should still receive a transplant, in my eyes.
Okay, that's brilliant. The other question was miniaturizing the pump. The concern that I have, Dr. Nicholas, is this, that we've seen a recall on the CentriMag. We saw a recall on the HeartMate 3 with the driveline, with the outflow graft torsion. They came up with that clip to stabilize it. We've now seen a recall on the HVAD. What options do we have for some of these patients who turn up at our doorstep if every single VAD or every single system continues to be recalled? What is your advice?
Yeah, that's a good question. And if they are young and if they are candidates for transplant, we had 2 patients out of our whole cohort. We do send them to Hermann for transplantation. And old patients in which the indication was destination therapy, we have to inform them. And if we have to change the controller, then it has to be under hospital conditions. Yeah, but it's difficult, and it's mechanical, and it's not biological. And I think we need some more steps in the development, like new surfaces that we can change anticoagulation. We need to get rid of the driveline or treat the driveline, that we can reduce these infections. In the Momentum trial, where we compared 2 and 3, we have seen more than 50% driveline infections after 1 year. This is a nightmare. And cardiologists, they realize, and that's why they do not want to transfer patients to us. And the amount of LVADs in Germany was reduced compared to the years before. And I do not think it's only due to pandemic. I think it's due to still technology which is not ready for long-term treatment. But I'm sure it will come, and I'm sure that it will be difficult in the future to transplant organs in Europe. And if we work on it, and if we have a complete implantable device, then the amount of numbers will be huge.
Great, thank you. I think we had a very good session. Let me thank both the great speaker, dear friend Hermann and Sebastian, and of course, Dr. Nicholas, join me and giving your overview on this. But anyway, on 24th of April, again, you are coming for as a speaker on cardiac arrhythmias. So that's again, we are looking for your session on that. With that, let me thank Sandeep for very nicely moderating this session. Of course, Dr. Gokhale for giving his views on this subject, and rest of the people who were, of course, log on to join this session. I'm sure when the pandemic will be end, we will be able to invite Herman and Sebastian, and of course, Dr. Nicholas Dahl in India. Maybe then we are going to have, hopefully in October, with SMICTSI workshop and Indian minimal invasive meeting. Let's see how that's folding. I think the vaccination is on the rapid way in India as well as the rest of the world. So we are very optimistic that definitely we are going to have in-person meeting. With that, thank you. Thanks for everybody and good night. You all made this really very fruitful session. Thank you.
Thank
Okay,
you.
bye-bye.
Thank you very much. Have a
Bye.
good one. Bye-bye.
Let's